A wise man once said, "To win a war, you need to prepare. And every battle is not won on the battlefield, but rather won during the preparation phase." Always do your best to read up on these principles, understand the concept, never memorize any answers, but understand the concept behind the answers. In this way, you will prepare to win all your academic battles and all your exams. Grab your piece of paper. This is season 4. Let's go. Hello and welcome to MK's Exam Secrets. My name is Dr. Moses Kazevu. These are series on my YouTube channel where we look at exam questions in a clinical course. This is season 4, episode 1, obstetrics and gynecology. If you haven't yet subscribed to the channel, please subscribe to the channel, hit the bell notification icon to be receiving notifications of such videos every time I post. Grab your piece of paper, grab your pen, and let's go. You already know the rules to these videos. You may actually pause the video before I give you the answer to think through the questions. Scream your answer at your screen, write it down on a piece of paper, and I will give you the answer in the next slide. Here's our question 1. A 60-year-old woman, G10 para 7, complains of a feeling of fullness in the vagina, which is noticeable when she is standing for a long period of time. The problem started 4 months ago. She has no other complaints and has never had surgery. Based on the information above, what could be your diagnosis? What increases the woman's risk for your diagnosis? Mention any two and describe the different types of the condition. So you may pause the video at this moment, write down your answers. I will give you 2 seconds to pause the video. And here comes the answer. So obviously from this question that has been given, this is a woman that has multiparity, increased parity, about G10 para 5. And she's 60-year-old. So already there's increasing age. There is these multiple pregnancies that she's had in the past. So this could only be pelvic organ prolapse because of the feeling of heaviness, especially when she's standing. So remember that risk factors that increase the risk of pelvic organ prolapse include increasing age, which this woman has, increasing parity, which this woman also has. You may have other causes like increase in intra-abdominal pressure, which may include obesity, chronic cough or chronic obstructive pulmonary disorders, heavy lifting, chronic constipation. It may sometimes be genetic predisposition or some connective tissue disorders. Now, the different types of the condition, so it may be classifying them according to the location or the organ contents. So from the anterior vaginal wall prolapse, you may have a cystocele, which is the descent of the bladder, a urethrocele, which is the descent of the urethra, a cystourethrocoele, which is the descent of the bladder and the urethra. It can be from the posterior vaginal wall, which can be a rectocele, which is the descent of the rectum, an enterocele, which is descent of the small bowel. Or it can be from the top, an apical type of thing, where it can be a uterocele or a ureto-vaginal type of prolapse, which is the uterine descending with inversion of the vaginal apex. Then you may also have a vaginal vault prolapse, which is post-hysterectomy invasion of the vaginal apex. You may also classify it according to the degrees of descent. So first degree, which is descent within the vagina. Second degree is descent to the level of the introitus. Third degree, which is descent outside the introitus. This is also referred to as procedentia. There is also a Baden-Walker classification. Grade 0 is a normal position for each respective site. Grade 1, there's a descent halfway to the hymen. Grade 2 is descent to the hymen. Grade 3 is descent halfway past the hymen. Then grade 4 is maximum possible descent from each site. Moving on to question 2. Mrs. RB, a 24-year-old in her first pregnancy at 32 weeks gestation, presents to the labor ward admission with a complaint of leaking fluid from her vagina. What is the diagnosis? What conditions would you ask her in the development of presenting complaint? List your differential diagnosis. What bedside examination would you do to confirm the leakage of fluid? What 4 clinical features would you look for in your bedside examination above? what 4 tests can be done on the leaking fluid. Briefly outline your management for this patient. You may pause the video at this moment to write down your answers, understand the question, and scream them at your screen. And here comes the answer. So the diagnosis here is obviously going to be preterm premature rupture of membranes. The reason why it's preterm is because it's happening before 37 weeks. And premature rupture of membranes is because there's this gush of fluid from the vagina before the onset of labor. So this is PPROM, as opposed to PROM, which is rupture of membranes at term, but before the onset of labor. So the conditions you want to look out for: cervical incompetence, multiple pregnancies, polyhydramnios, antepartum hemorrhage, hypertensive disorders of pregnancy, urinary tract infections, diabetes mellitus. These are the conditions that commonly cause preterm premature rupture of membrane. So you want to tackle those in your presenting complaints. Then the differential diagnosis, it could be hydroria gravidarum, which is a discharge that's associated with pregnancy. It could be urinary incontinence. You could have some vaginal discharge. You could have liquefied sperms after sexual intercourse, because pregnant women also be doing the most lately. So what bedside examination would you do to confirm the leakage of the fluid? So you want to perform a sterile speculum examination. You're not going to perform a digital examination, a digital pelvic examination, because you don't want to keep introducing your fingers into that area. That creates now a possibility of infections actually happening. Now, the 4 clinical features that you may be able to see when you actually perform your sterile speculum examination is: number 1, you may see the fluid actually leaking out from the cervical os. So that's the first clinical feature. Then second thing that you can actually do, you can ask the mother to bear down or to strain down or to cough, and you'll be able to see the fluid, even more fluid trickling down from the cervical os. You may also see pooling of fluid in the posterior fornix of the vagina, and of course the cervical os itself will be closed, so it won't be dilated. So those are the things that are going to be now pointing you towards this woman having premature rupture of membranes. You may sometimes not even be able to visualize if the cervix is open. In such a case, you may not be able to visualize the membranes because they would have already ruptured. Then what 4 tests can be done on the leaking fluid? So you may perform a nitrazine paper test, which turns yellow, from yellow to blue if it's the amniotic fluid. You may perform a microscopic fanning test of the fluid. So you get the fluid, you apply it on a glass slide, and you allow it to dry. It will look like a leaf pattern. You may also perform lecithin sphingomyelin ratio levels. These are just pretty much helping you point towards lung maturity. You may also check for the levels of the phosphatidylglycerol levels, also to point towards fetal lung maturity. You may also do a microscopic calcium sensitivity of the fluid to rule out any infections. Then the management of the patient. Recall that this patient is at 32 weeks gestation. Very important. So you want to confirm the diagnosis. You want to determine whether the patient is in labor or not, and you look for any evidence of any sepsis. And in this case, there is no sepsis, so we're going to manage this person conservatively. So we want to admit the patient. Bed rest is very important. Send the labs. So we're going to do a high vaginal swab, an endocervical culture, a urine culture, and FBC. We assess for uterine contractions, preferably daily. We assess for the fetal heart rate, the maternal pulse rate, and the temperature 4 hourly. Then we also assess for any labor, chorioamnionitis, or even placenta abruption each and every single day. We ascertain the lung maturity. So generally, the lecithin sphingomyelin ratios must be 2 or greater than 2, and this actually indicates fetal lung maturity. Otherwise, if the fetal lung maturity is not assured, you can give steroids. So that's your intramuscular betamethasone, 12 milligrams IM intramuscular injection once a day for 2 doses, or dexamethasone 6 milligrams twice a day IM for 4 doses. Then, of course, send your cervical cultures and the FPC on admission. Start them on a 7-day prophylactic antibiotic. So you can give ampicillin 2 grams IV every 6 hours for 48 hours. Then amoxicillin 500 milligrams 3 times a day, and erythromycin 250 milligrams QID 4 times a day, or azithromycin 1 gram POOD for as azithromycin is given for 3 days, but the other drugs are going to be given for 5 other days, so a total of 7 days. Then you deliver them once they are at term, and if vaginal delivery is expected, you may use oxytocin or prostaglandins as indicated. Otherwise, you should perform a cesarean section. Remember, tocolysis is contraindicated because there is a high risk of having a lot of infections in this area because the membranes have ruptured. So question 3, you are a clinician on duty. A 16-year-old girl walks into the gyne clinic. On inquiry, she tells you that she noticed some vaginal bleeding with abdominal pains. Further inquiry reveals that she is 12 weeks pregnant. You decide to conduct a vaginal examination. The cervix is 4 centimeters dilated and products of conception felt in the vagina. What do you think is the problem? How would you manage this case? So you may pause the video at this moment, and here comes the answer. So remember, keep in mind, this girl is 12 weeks pregnant, has vaginal bleeding, abdominal pains. You examine her and the cervix is dilated with products of conceptus. So there are two things that people may debate on. There's a group that's going to say this may be an incomplete abortion. There's a group that's going to be saying this may be a threatened abortion. The difference is this. So the answer here is most likely this is an incomplete abortion. The difference between incomplete and a threatened abortion, or rather inevitable abortion, not threatened, inevitable abortion, is that an inevitable abortion, the cervical will also be open, but you won't have the passing of those products of conceptus at the cervical ostium. But you do have that with incomplete abortion. So this is most likely an incomplete abortion. So this patient actually, you want to admit them, you assess the hemodynamic status, you stabilize them, so give IV fluid, preferably your isotonic fluids, your normal saline, blood transfusion for this patient, so do a cross-match, do a full blood count, IV fluids and blood transfusion if they're in shock, give them misoprostol 600 micrograms orally or 400 micrograms sublingual, offer them some bereavement counseling and family planning after this whole process. If they are Rh negative, they do require anti-D antibodies. Then cover them on antibiotics after the procedure. 100 milligrams doxycycline orally once a day. Metronidazole, that's given at 400. The oral dose is 400, not 500. 400 milligrams orally twice a day for about 48 hours. Then surgical intervention is also needed, so manual vacuum aspiration with analgesia, so you may perform a paracervical block, and you send the specimen for histopathology and karyotyping. Question 4. You have successfully conducted a spontaneous vaginal delivery on a 25-year-old woman. What assessment of the mother should be done in the immediate postpartum period? When should the woman return for her first postnatal visit following discharge from the hospital? What are the common causes of vaginal bleeding after 24 hours postpartum? Mention 2 causes of puerperal fever. You may pause the video at this particular moment. And here comes the answer. So generally, you want to monitor the mother for at least an hour after they deliver. We call this as the 4th stage of labor. So you want to look out for the maternal vitals. You want to look out for the uterine retraction. You want to look out for any vaginal bleeding, because that's the high risk time where the mother can actually deteriorate, the first hour or so after the delivery. Then the mother should actually come back for the first postnatal visit. Ideally, should be within the first 3 weeks of delivery. If it's a high-risk pregnancy, it should be within the first 10 days of pregnancy. For example, if they had hypertension in pregnancy. And the common cause of vaginal bleeding after 24 hours, remember this is secondary PPH. 2 important causes are going to be retained products of conceptus and infections. Then 2 causes of puerperal fever include endometritis, septic thrombophlebitis, and urinary tract infections. Question 5, and we're halfway. Mrs. AM is a 19-year-old who delivered her first child 7 days ago by spontaneous vaginal delivery. She was complaining of abdominal pains associated with a foul-smelling discharge and a fever for 2 days. Define puerperopyrexia and puerperosepsis. List 8 possible causes of puerperopyrexia. List down 4 risk factors for puerperosepsis. List any 6 clinical signs you would look for during abdominal and pelvic examination. How would you manage this patient? You may pause the video at this particular moment, read the question, write down your answers, and here comes the answer. So puerperopyrexia is just simply a temperature that's greater than 38 degrees Celsius on any 2 days of the first 10 days following delivery, exclusive of the first 24 hours. Then puerperosepsis is an infection of the genital tract which occurs as a complication of delivery. So causes of puerperopyrexia include endometritis, urinary tract infections, wound infections, puerperosepsis itself, mastitis or breast abscesses, pulmonary infections such as pneumonias, septic pelvic thrombophlebitis, pharyngitis, and even gastroenteritis. And 4 risk factors for puerperosepsis include antepartum risk factors like malnutrition, anemia, preterm labor, premature rupture of membranes, HIV, prolonged rupture of membranes greater than 18 hours, diabetes, and intrapartum risk factors include repeated vaginal examinations, dehydration and ketoacidosis during labor, traumatic vaginal deliveries, prolonged labor, obstructed labor, and even cesarean delivery. Then 6 clinical signs you would look for include a copious and foul-smelling lochial discharge, subinvoluted and tender uterus. You may have an infected wound in the perineum, the vagina, or cervix. You may have tenderness on either side of the hypogastrium. And then on vaginal examination, this may actually show a unilateral tender indurated mass pushing the uterus to the lateral or to the contralateral side. You may have cervical motion tenderness. You may also have a bulging fluctuant mass in the posterior fornix, which may indicate fluid in the pouch of Douglas. Then how would you manage this patient? So we generally admit the patient, we transfuse them if they're anemic, and we give them antibiotics. We should be able to follow the sensitivity patterns once we get the results for the couches. However, we start off with gentamicin, 2 milligrams per kg IV as a loading dose, followed by 1.5 milligrams per kg every 8 hours, together with clindamycin, 800 milligrams IV every 8 hours, and metronidazole, 500 milligrams IV TDS for 7 to 10 days. Generally, surgical management has no significant role, but it may have a role in a few selective cases. Then moving on to question 6, a couple presents to you with a history of not being able to conceive for 2 years. What is infertility? What are the causes of infertility? What questions would you ask this couple? What investigations would you want to do for the couple? So you may pause the video at any point, and here comes the answer. Remember that infertility is divided into primary infertility and secondary infertility. In primary infertility, they've never had a child before. Secondary infertility, they have had a child before. So the definition is as follows. So this is inability to conceive after 12 months of regular, unprotected sexual intercourse in the absence of a genital pathology, either in the absence of a previous pregnancy, which is primary infertility, or after a previous pregnancy, secondary infertility, in individuals that have attained sexual maturity. So the causes can be divided into male factors and female factors. Male factors include oligospermia and obstruction to the ductal system. Female factors include hypoprolactinemia, pituitary insufficiency, polycystic ovarian syndrome, hyper and hypothyroidism, androgenaxis, Asherman syndrome, endometrial polyps, uterine malformations, submucosal fibroids, tubal adhesions, and tubal blockages. Questions that you'd want to ask: what's the regularity of their sexual intercourse? What's their work schedule of the couple? Do they stay together? Are they in different towns? Do they just meet once in a while? Is there any history of trauma to the pelvis in the male? Is there any history of regular monthly menses in the female? Is there a history of a previous pregnancy within this marriage or outside the marriage or outside the same interaction? What's the HIV status of both partners? Is there any family history of infertility? Investigations that you'd want to do for the couple: most people often forget the male, so do not forget to do a sperm analysis. Read up on a sperm analysis and the different types of findings that you may have and the parameters that you'd look for on a sperm analysis. Then hormone profile is going to include prolactin, FSH, LH, estrogen, TSH, T3, and T4. You may also do a progesterone and an estrogen-progesterone challenge, a pelvic ultrasound, a hysterosalpingogram, plus or minus a diagnostic laparoscopy. Moving on to question 7, Catherine, a 27-year-old woman, presents to the gyne department at Ndola Teaching Hospital with a history of 8 weeks amenorrhea, abdominal pain of sudden onset, pervaginal spotting, and history of fainting. Previously, she was attended to at the STI clinic at Kalulushi General Hospital and was treated after genital swabs were positive. She has a stable partner but was involved in 3 relationships and also gives a history of oral contraceptive use. Examination findings include BP 70/56, pulse 134, Abdomen was soft, right iliac fossa tenderness. Vaginal examination showed mild dark blood on the glove. Initial imaging and laboratory findings were as follows. Urine pregnancy gravidex test, there were no reagents. HB was 4 grams per deciliter, platelets 156. Pelvic ultrasound showed a right adnexal mass with ascites. Uterus is empty. What is the most likely diagnosis? Outline the risk factors for this condition. What complications are likely to arise from this condition? Briefly outline how you would treat this patient based on your diagnosis above. You may pause the video. And here comes the answer. So now that I've read the question actually during this video production, I'm actually going to change my answer a bit. So instead of saying shock secondary to ruptured ectopic pregnancy, I'll just say shock secondary to ectopic pregnancy. So with the ruptured here, I still have a bit of some reservations concerning that. But anyways, this woman here is in shock. You can see a BP 70/56. So you can just say shock secondary to an ectopic pregnancy. So the risk factors include a previous history of ectopic pregnancy, PID and STIs, which can lead to scarring and adhesions in the fallopian tube, number of sexual partners, which is linked to STIs, use of intrauterine devices, which can also lead to scarring and adhesions, history of previous obstetric, pelvic or tubal surgeries, which can cause scarring, increase in maternal age above 35 years, prior induced abortions, and even assisted reproduction technology. Then complications include rupture, infections, peritonitis, septicemia and septic shock, hemorrhagic shock, future ectopic pregnancies, increase in risk of hysterectomy, infertility, and death if you're one of those few people that believe death is a complication. Then how would I manage this patient? So ABCs. Ensure that the airway is patent. Give this patient oxygen. This patient has an HB of 4 grams per deciliter. Monitor the vitals and SpO2. Gain IV access with 2 large bore cannulae. Start running IV fluids, preferably normal saline, but this patient needs blood. So you need to transfuse this patient with blood. So send blood for a cross match. Then, of course, definitive management is surgical management. So you have to perform an emergency explorative laparotomy. Then question 8. A 30-year-old G4 para 3 is admitted to the labor ward at 38 weeks gestation, complaining of severe headache and blurred vision. Her BP is 200/110 with proteinuria 2+ on urinalysis. Recent BP a few hours later is 160/110. Going by history and blood pressure examination, you decide she has preeclampsia. Define preeclampsia. What type of preeclampsia does this woman have? List 5 risk factors of preeclampsia. You decide to give a loading dose of 4 grams magnesium sulfate, IV. The nurse tells you that there is only 50%, it's supposed to be 50% solution here. 50% solution available on the ward. How would you make the desired solution from the available 50% solution? So this should be solution, not dextrose there. And here comes the answer. So remember that preeclampsia is a sustained BP greater than 140/90 on at least 2 separate occasions, at least 4 to 6 hours apart, after 20 weeks of gestation, in the absence of pre-existing hypertension, with at least 300 milligrams of protein loss in the urine in 24 hours. Although we don't really use protein loss as a good measure, we use other ratios, the ACR and PCR ratios, to actually determine whether someone has significant proteinuria or not. Then what type of preeclampsia does this woman have? She has severe preeclampsia. Why? The BP is quite high. And second, she has end organ damage. She has severe headaches and she has blurred vision. Then 5 risk factors include premiparous women. It's 8 times more common in these. Previous history of preeclampsia, multiple gestations, obesity, a BMI that is greater than 30. The family history of preeclampsia, DM, age greater than 40, age extremity, so 10 years or more since the last baby. So now, I want to talk a little bit about the dilution of magnesium sulfate because it's very important that you know this. So there is a regimen that we use for patients that have severe preeclampsia and patients that have eclampsia. We do put them on magnesium sulfate. So magnesium sulfate is going to be given as 14 grams as your loading dose 14 grams. So you're going to be giving 4 grams as IV, and you're going to be giving 10 grams as a deep IM, so 5 grams in each buttock. So the formulation that you're going to be given as IV should be given as 20% magnesium sulfate. So it has to be diluted. You can't give the 50% magnesium sulfate. It will cause a lot of side effects and the patients can actually die. Whilst the one that you give at the buttock can be given as 50% magnesium sulfate, there's not so much issue with that. So you can give it as the 50% magnesium sulfate, no need to dilute it. So the question here is asking you, how are you going to give the 4 grams of magnesium sulfate when you only have 50% solution on the ward? You don't have the 20% solution. And most of you will find yourself in this particular scenario on the ward. And you may be working with a nurse that is new on the ward and may not know how to do the dilution. So pay close attention. So you want to give a total of 14 grams, right? So the magnesium sulfate is going to be given as 4 grams IV. So this one that you're giving as the 4 grams IV is given as 20%, not 50% magnesium sulfate, but 20%. So you're going to be giving a total of about 5 to 20 mils of it IV. And then the deep IM, the 5 gram in each buttock, can be given as 50% magnesium sulfate. So this one is not a big issue. So you give it along with 1 ml of 2% lignocaine so that it doesn't hurt, because it's quite painful while injecting. So this one doesn't need to be diluted. The ones that you're giving as the 5 grams in each buttock, it's okay. You don't need to dilute it. The one that you need to dilute is the one that you're giving IV. So if you look at the vial of the magnesium sulfate, the 50% magnesium sulfate, it will give you this compound here, or this formulation, 2 millimoles is going to be equal to 1 ml of the same 50%. So, and the vial itself is 10 mils. Okay, so when we say that this is 50%, what exactly do we mean? We mean 500 milligrams of magnesium sulfate are present in 1 ml. So 1 ml is equals to 500 milligrams of magnesium sulfate. And remember that the whole vial of the 50% magnesium sulfate is 10 mils. So if you're taking the whole 10 mils of it, if 1 ml is equals to 500, then 10 mils is going to be equal to 500 multiplied by 10. So 10 mils will give you 5,000 milligrams. That's about 5 grams. So if you take the entire vial of the magnesium sulfate, the entire 10 mils of the 50% magnesium sulfate, you're going to be getting 5 grams. But remember, we don't want 5 grams. We want 4 grams. So if 10 mils gives you 5 grams of the 50%, how much will 4 grams be? You say X mils. So 4 multiplied by 10 is going to be 40, divided by 5 will give you 8. So for you to get 4 grams of 50% of the 50% magnesium sulfate, you need to get 8 mils from the container. So you're going to get 8 mils from the container. But this 8 mils that you're getting, remember that this 8 mils is 50% magnesium sulfate. You can't inject that into the vein of a patient. The patient will die. That's too concentrated. So you want to dilute it to 50%. So there's a very simple formula that you actually need to follow to see how much you need to dilute it by. So you say the available concentration, which is your 50%, divided by the required concentration, which is your 20%, minus 1. So 50 divided by 20 is 2.5. 2.5 minus 1 will give you 1.5. So it means for every mil of magnesium sulfate 50% that you get, you need to add 1.5 mils of water for injection to dilute it to 20%. And since you have 8 mils, how much water for injection do you need to add? So 8 multiplied by 1.5 mils, which will give you 12 mils. So the instructions that you're going to be giving the nurse to make up the 4 grams, you're going to tell the nurse, get 12 mils of water for injection or 5% dextrose and add it to 8 mils of 50% dextrose of the magnesium sulfate. So you're going to be giving a total of 20 mils of the solution. So this will now be 20 mils of 4 grams of 20% magnesium sulfate. I hope that makes sense. So this is the answer up to this point. Now remember that if a patient now starts seizing, you need to give an extra 2 grams of magnesium sulfate IV. Remember, if 5 grams is equals to 10 mils, how many mils are you going to get for 2 grams? So it means you need 4 mils from 2 grams. But remember, this 4 mils is 50%. You need to dilute it to 20%. So you multiply this 4 by 1.5. So that gives you 6 mils. So you need to get 6 mils of water for injection with 4 mils of the 50% of the magnesium sulfate for you to get the 2 grams IV magnesium sulfate, which is at 20%. Remember, we give the IV at 20%. The IM can be given at 50%. I really hope that makes a lot of sense. If you didn't understand, please rewind the video back and actually play through it slowly and you will understand the concepts. Then moving on to question 9. A 47-year-old woman presented with complaints of postcoital vaginal bleeding and persistent offensive vaginal discharge. Her pelvic examination revealed an ulcerative tumor arising from the cervix. Histopathology report of the biopsy confirmed squamous cell carcinoma of the cervix. Clinically, what are the different types of cervical lesions, i.e. on naked eye appearance? List 5 risk factors for cervical cancer. What are the 3 main things that cause death in cervical cancer patients? What investigations would you recommend for this patient? List the treatment modalities for cervical cancer in general according to clinical staging. What is the best treatment option for cervical cancer stage 1B1 with minimal complication, and state the reason why? You may pause the video and scream your answers at your screen, write them down, and I will give you the answer in the next 30 seconds. And if you're enjoying these videos, please consider subscribing to the channel. Hit the bell notification icon to be receiving notifications on our road to 4K subscribers. We really hope to reach 4K very soon. And the next big target actually will be 5K subscribers. So if we can reach 5K subscribers before June the next year, then that will be great. And you guys will make my next year. So please keep telling people to subscribe to the channel, hitting the bell notification icon. You can actually personalize the videos that you can want to receive, whether you want to receive a notification for all the videos I post or just specific videos of which I post when you click on the bell icon. So do not forget to do that before you actually head out from this video. I hope now you have understood the question, and here comes the answer. So remember, when you're doing your examination of the cervix, you may see certain things, especially on colposcopy. So you may see what is known as this whitish acetal or whitish epithelium, acetal white epithelium. So it's just this area that appears whitish in color. Sometimes when you actually look at it, you may get what is known as a mosaic pattern. You may sometimes even see different types of patterns. You may see some atypical blood vessels. You may see an ulcerative mass or fungating mass that you may see. So clinically, you may see these things when you examine the patient. Then 5 risk factors for cervical cancer are going to include persistently high risk HPV infection, things like 16, 18, 31, 33, 35, 45, 56, increase in sexual activity, especially those that have early age of intercourse, less than 17 years, multiple sexual partners, sexually transmitted diseases, especially the ulcerative ones, age greater than 30, immunosuppression. In our case, HIV is the most common cause, low socioeconomic status, early first pregnancy, too many or too frequent births. Then 3 main causes that may cause death in cervical cancer patients include renal failure, pulmonary causes, and hepatic failure. Investigations are pretty much going to be targeted towards checking whether this cancer has spread to certain areas. So you want to do a cystoscopy, a sigmoidoscopy, a proctoscopy, liver function test, a chest x-ray, a contrasted CT scan, abdomen, as well as the pelvis. And the treatment modalities for cervical cancer are going to include those that are at stage 0 to stage 1. So laser or cryotherapy of the endocervix, loop electrosurgical excision procedures or code knife cone biopsy for the ectocervix can be done. Total abdominal hysterectomy can be done if they have completed childbearing. Then, of course, conization or cryotherapy can be done if the patient wants to retain their uterus. If it's 1B to 2A, modified radical hysterectomy or radiation, pelvic lymphadenectomy, para-aortic lymphadenectomy, and then stage 2B. Anything above stage 2B is pretty much palliative care, so chemotherapy with cisplatin as well as radiation therapy. So this patient who's at stage 1B, you want to perform a modified radical hysterectomy. You may also perform pelvic lymphadenectomy, para-aortic lymphadenectomy, and this is because the cancer is largely limited to the pelvis, it's largely limited to the cervix. So it hasn't yet spread outside the pelvis, it hasn't yet spread to the significant areas. Then question 10, which is indeed the last and the final question. Juliet is a 38-year-old G6 para 5 at 2 weeks pregnancy with no living child. All her previous pregnancies were IUFDs that happened between 28 to 32 weeks. Patient is asking how to monitor her pregnancy. Outline the investigations you would do in the antenatal period to establish the cause of the poor fetal outcomes. Justify your choices. Discuss the various options available for fetal monitoring during the antenatal period. Describe the options available for monitoring the well-being of the fetus in labor. Outline the delivery plan for this patient. You may pause the video, and here comes the answer. So you want to do a pelvic ultrasound to rule out any circumvallate placentation or placenta previa, VDRL or RPR, serum toxoplasma antigen test, HIV to rule out infections, anticardiolipin antibodies, antiphospholipid antibodies, and antinucleic acid antibodies to rule out autoimmune conditions, because these are common causes of third trimester losses or third trimester death. Then you may also do a RH grouping for erythroblastosis fetalis. Now, the options that we have for monitoring the fetus during the antenatal period, we may do an ultrasound, which is performed as a part of fetal surveillance. It can be done periodically throughout the pregnancy and is often going to be used to monitor the development of the fetus and, of course, the intrauterine conditions. We can also perform a non-stress test, which measures the baby's heart rate and the fetal movement over a specific period of time without any external factors being applied. So here we just monitor the heart rate externally with a sensor that is going to be attached to to a belt, and it's going to be placed on the mother's abdomen. So here there's no risk to the mother or risk to the child. And then we may perform a contraction stress test where we measure the baby's heart rate in response to uterine contractions. So here the test is going to be administered with the same sensor with the belt around. But in this case, the contractions are going to be either physically or chemically induced, and then we measure the heart rate under these altered conditions. We may also do a biophysical profile, which combines the ultrasound and the non-stress test to determine the baby's heart rate, the breathing and the body movements, as well as the fetal muscle tone and the amount of amniotic fluid around the baby. Then the options available for monitoring fetal well-being of the fetus in labor. So we may do clinically, where we intermittently auscultate the fetal heart rate and check for the meconium in the liquor, a biophysical profile, or actually biophysical monitoring, where we look at the continuous electronic fetal heart rate monitoring through an external and internal modality. We may also do an ultrasound as well as some biochemical modalities. Then we generally want to admit this patient early, preferably around 25 weeks or earlier than that. Investigate if there's any lung maturity, give corticosteroids to help with the lung maturity. Then definitive management is largely dependent on the underlying cause. So if we determine that infections are the ones that are causing this, we treat the infections. And once the fetal lung maturity has been assured, we can induce the pregnancy or we can deliver it by C-section. Of course, the baby should be admitted to the NICU. Then here's a question that I just want to leave on your minds. You can actually leave your answer in the comments below, and we can start a discussion. A 44-year-old primigravida presents at 19 weeks in her first pregnancy. She has a blood pressure of 160/100 and urine dipstick shows 3+ proteinuria, complaining of slight headache, and is very sure of her dates and gestational age. What is the most likely diagnosis and what is your rationale for the decision? What are the differential diagnoses? Why is ultrasound scan specifically important in this patient? What other 4 investigations will you do? The patient is eventually diagnosed with severe preeclampsia. What are the principles of management of severe preeclampsia? Leave your comments below. I will leave a pinned comment of the comment that I think makes the most sense and has a very meaningful discussion. If you enjoyed this video, consider subscribing to the channel. We leave no one behind. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.